Thank you. So, delightful to be here. Thank you for having me and for coming along on such a glorious sunny afternoon. I see the weather just turned right in time for giving the talk, so, we all understand we could be outside. I'd like to also acknowledge that my now PhD student Carly is here. She didn't come all the way from Australia just to see this, but Carly was the study coordinator on this trial as well before she undertook her PhD. So if you ask any curly questions, I'm going to throw them to her at the end anyway, but that's delightful to have her in the audience as well. And you can all see the talk is about the participation paradox and reevaluating it in light of experience-based co-design. And it is something that I am quite passionate about. Paradoxically, I did my thesis on cooperatives and qualitative study, looking at ethical and moral communities, and then I've moved on to undertaking this step wedge trial. So I do find myself in a little bit of a paradox anyway. And I want us to think a little bit today also about this concept of value and re-evaluating it as we go along. But before I do that, I'd like to situate the trial in the context of a number of different trends. And I suppose everyone is familiar here. It's no surprises that we're participating in healthcare in many and varied ways. We've got self-tracking, we've got data, and that also spans across to healthcare improvement. And then we also have this confluence of the experts by experience movement and greater acknowledgement of the importance of lived experience. And then within that also, we've got this government push to have service users and carers and staff all involved in participating in improvement initiatives. And our trial was situated in the context of this, and really I think we were reflecting in the taxi almost at the beginning of a bit of a wave that's started, and also in the context of a really big push towards recovery orientation in mental health services. So when we took this trial up, we were thinking about these things that were happening. And you don't need to read all of the content here. Don't be worried, I won't be giving a test. But this is really just to highlight how we've seen this participatory push happening in mental health. And at the top, I've cherry-picked a few international documents that have called on involvement and linking it with recovery. You can see the 2011 UK Government No Health Without Mental Health document, up until recently the 2017 UN report on the attainment of physical and mental health, looking at the role of co-production as a model for participation in services. And along the bottom, the red line shows that in Australian mental health policy, we've seen this big push and move towards experience, and the orange line is showing how co-design and co-production have started to come on to that policy landscape. They overlap, and increasingly we're starting to see more and more reference to co-design and co-production and less so to the experience side of things. It doesn't mean that we're not using your experiences matter surveys in Australia and things like that you also have similar versions of here, but we are seeing a big push towards co-design and co-production. And this is also happening in this context of engagement, and some of you might be familiar with this quote from Health Affairs, and Carmen et al. Wrote on it in 2013. And this suggests that patient engagement has been posited as a necessary condition for the redesign of healthcare systems, the holy grail of healthcare, and the next blockbuster drug of the century. And there's this idea in which involvement, engagement, and participation are doing something. And these are all framing up our interest in thinking about experience-based co-design, and in particular mental health experience co-design in the trial. Just to reinforce that, in Australia, our last national mental health plan that was developed suggested that governments recognise and emphasise the role of consumers and carers in overseeing improvements to mental health care. And I'll just pause there and suggest that our government's still a little bit behind in its terminology. It likes to refer to people as consumers, and we tend to have a bit less emphasis on lived experience and service users. So I might shift in my terminology throughout the talk as a result. So they promote consumer and carer participation in policy and oversight and co-design models of care and service and program reform. So co-design has developed internationally as an inclusion principle, for the delivery of public services. So there's these pushes and things afoot. But before I go on, so I happened to arrive on Tuesday last week. I can't keep claiming jet lag, but I will. And I stayed at the Premier Inn across from the British Library. So I happened to be able to make my way over to the Da Vinci exhibition for A Mind in Motion. And then I thought, oh, there's some analogies here that I'd like us to think about today. And then I discovered we were in the anatomy lecture, so I really thought this has all come together too nicely. But Da Vinci and these analogies are really interesting to me, and it's not about me doing any drawing and thinking about those things, but the ideas that Da Vinci had around the study of human anatomy and movement are important. So Da Vinci suggested that there was a science of mechanics, and he saw it as a necessary foundation for the study of human anatomy and movement. And he was very interested in motion in all its forms, not just in the bodily sense of how we move our body, but also in emotion and how those emotions are expressed. And so I was thinking, that's interesting. And I was reflecting on this confluence of trends and this participatory era to suggest that perhaps it's time that we start to think about a bit of a science of participation and start to think about what is it that's happening when we're bringing people into spaces, when we're looking at co-design and co-production, what's going on? How do we measure it? How do we know what we're doing? What works for whom, when, where and how? And so the core study in many ways is the beginning of that science of participation for us. And it was funded by the Victorian Mental Illness Research Fund and the Psychiatric Illness and Disability Donations Fund. And that was a particular $10 million pool of money that the government had put together, and they only funded 5 projects within it. And it was a very interesting experience because they funded the 5 projects, they changed government, and we had all of these changes to who was looking after them, projects, and how we now translate our work into that setting is quite different and difficult as a result. So with all those trends in mind, we started to think about a hypothesis, and the focus of today is really our primary hypothesis. And that was, can a mental health experience co-design intervention aimed at making community mental health services recovery-oriented result in improved psychosocial recovery outcomes for people living with severe mental illness? We also had some secondary hypotheses that implementing the mental health experience co-design would improve carer quality of life, would have changes to staff recovery attitudes, and would see some changes in recovery orientation of services. I'm not going to go through the results of every single part of the trial. It's very large and enormous. You'll have to read the paper instead going forward, but we'll focus on largely the service user component. So as Glenn mentioned, the anatomy of the trial was a stepped wedged cluster randomised control trial. Now, this was an open cohort design. So what we had was everyone was recruited at the first time point all at once, and then we moved into the 3 waves of the interventions. The clusters were the teams within 4 community mental health services, and they came on 3 at a time. So you can see that by the time 1, 2 and 3 there on the slides. In a step wedge design, ultimately the intervention and the people not receiving the intervention are acting as the control. It's a much more robust design than a pre-post analysis. And we also felt that there were some ethical components to delivering the intervention, and that by the end of the trial it seemed better that everyone would get the intervention. So ultimately those are the rationales why we undertook the step wedge design. So we had follow-up up to 27 months, and the intervention itself was 6 months long. We allowed people 1 month to implement, and then we also undertook our measures at those points in time. So these blocks are 9 months each time point. We were really interested, as I said, in recovery, and we selected the recovery assessment scale, the revised version. One of the reasons for that was that we'd spoken with some people with lived experience. They answered other forms of the Maryland assessment for recovery and various other questionnaires, and they liked how the recovery assessment scale was easy to answer. We could administer it by telephone, and it seemed to have been developed from interviews with people with lived experience, so we thought this might be an appropriate measure. Our secondary outcomes were quality of life, so the Euros is the brief WHO-QOL version of quality of life. And for staff, we looked at that recovery self-assessment and staff attitudes to recovery. In particular, in the recovery assessment scale, we were interested in the subdomains, and they are personal confidence and hope, willingness to ask for help, goal and success orientation, reliance on others, and no domination of symptoms. So we had a bit of an assumption that mental health experience co-design as a quality improvement intervention would increase that personal confidence and hope. And these kind of questions are part of our process evaluation analysis. They're a sub-analysis within the trial, but overall we've looked at the primary outcome of whether individual recovery improved or not. So then we set out to recruit people. We had 30 people per cluster, so 30 service users. We hoped to recruit 30 carers, but we had a lot of difficulty, as Carly will remember nodding her head there, trying to identify and recruit carers, and we recruited staffers according to how many were on the team. And this here it describes the relational model of engagement that we tried to develop. We worked with the sites to develop different recruitment strategies. We had people on the ground developing artwork, and we had flexible participation measures. So that open design meant that people could be part of the longitudinal study, so they could participate at every time point if they wanted to, or they could tap in and out as cross-sectional data. So we had about 133 people, I believe, who stayed in from the beginning to the end, which is pretty good for people who have living with complex mental illness for a 27-month follow-up period, and the rest were cross-sectional data. At our recruitment days, we also had peer workers to support people, and we also tried to use a model of comedy in Stand Up for Mental Health from the Canadian group that David Graniera runs, and we had people with lived experience coming along, trying to reduce some of the stigma around mental health, and also to make things a little bit more interesting and say, well, not all research is boring, please sign up and take part. We also had our lived experience investigators in Rosemary and Wayne, and they delivered the intervention to everywhere across Victoria that we were involved. And I think I was working out, it translates to about 90 hours of delivery, but then on top of that is all the travel. I'm just trying to think, we need to find the hours at some point to give the scale. 10,000 kilometres. So by the end of the trial, we had 287 people recruited, predominantly female. As I said, there were 61 carers, so everyone reported whether they had a carer or not, and at least half of the people suggested that they didn't have a carer. So it makes sense that it was difficult to recruit carers on the one hand, but on top of that, lots of people don't have them, and then the services didn't have the details about people to recruit them. So it's a real big gap in the field. And 137 staff took part in our first survey. Most people had had mental health conditions for 18 to 19 years, and the staff had worked in the services for about 6 years. But when we take that down to the next level again, I want to think about Amanda, who took part. So she was 46 when she joined the study, a bit of a spring chicken, same age as me. She completed a certificate and a diploma. She reported having had a diagnosis of bipolar and trauma and agoraphobia and depression. Suggested that she had a carer and a friend that they lived with, had 4 important people in her life, including her mum, and reported also having lots of physical health problems, migraines and gastro ulcer and various other things. She'd been hospitalised and admitted to a facility more than 3 times, and her access to the mental health community services that we were working with was around coping with everyday stuff helping with her recovery plan, her legal stuff, facilitating things that she can't get to on her own, and going to an art gallery to have some of her works displayed there. And the last little bit about the then and now is her self-report of times of feeling unwell and better, using a timeline approach. And you can see that she sort of has had a decline and then a bit of a flat line going on there. In Amanda's typical week, she'd feel no energy. Her carer made her go out. That didn't help. It made her feel exhausted. She was very low and painted, restless. Tuesday was the same as Monday. And then by Wednesday, she felt that she'd become a bit manic, listing everything for everything, and then cleaning everything and anything. And I guess I'm highlighting Amanda because when we talk at the level of a trial, 287 people, we lose connection with some of the people that we're involved in. And some of the reasons that we're talking about value here in the participation paradox are around some of the trial outcomes that we'll talk about later, and the kind of work that people need to do to come and take part in something like mental health experience co-design is something that we have to evaluate very seriously and clearly. So what was this thing, mental health experience co-design? So up here is Wayne and Rosemary, who Glenn helpfully introduced earlier for us. And Wayne at the time was working at the Victorian Mental Illness Awareness Council, and Rosemary was with Tandem representing the mental health carers of Victoria. And for about 6 years before we came on board and undertook the trial, they had been working up this methodology, and they'd started with a bit of a survey approach, and then they decided they needed to implement the next stage, which was co-design. That work was piloted in youth services and other rehabilitation services in Victoria. So Rosemary and Wayne were on the team, and as I said, they delivered the intervention in every site across Victoria. So even though we had 9 clusters, that translated to 19 different sites that we had to go out and visit and run different groups at as well. So you won't necessarily be able to see this. I'm going to unpack it a little bit more in the next few slides. But this is just to highlight there are 2 stages to mental health experience co-design following the EBCD model. There's a gathering phase looking for experiences. In our approach, we adopted telephone interviews to talk about experiences. So one of the reasons for that was that we were undertaking a trial on the one hand, and we also were working across the whole state. We wanted to be able to reach as many people as possible to get the feedback about what was going well and what could be improved. So that was one of the rationales for looking at the telephone interview approach. In that model, we then had some focus groups where we looked at the touch points that had emerged. People discussed those. We prioritised. I love you've got Post-it notes on your computer on the outside just to demonstrate. We used some Post-it note prioritisation, and we then identified the improvement areas. And the co-design phase itself involved some training for people. So the service users and the carers came together on their own first and talked about group processes, talked about what it would be like to work with the staff to unpack some of those power dynamics. And then the staff joined and we talked about the whole methodology as it would unfold. So it was undertaken over 26 weeks. Before we worked with people, we also said, well, what kinds of levels of engagement have you had at services before? And really, people had really just been involved in the rather perfunctory levels of completing surveys and questionnaires, feedback forms, writing a letter if they didn't like something, community forums, and being a member of a consumer advisory group at other points in time. So fairly stock standard levels of involvement. In terms of talking with people by telephone and for that experience phase, we did reach about 153 people of the 217 who were eligible, so 70% completed a telephone interview. That's of the service users, about the same for carers. So that's important because often people say, well, you know, were you working with the things that mattered to everyone at the service? And so we feel confident in saying that's a pretty good representation of that group. The reach was variable from about 65% to 90%, And some of the reasons for that were obviously around time, life, being unwell at the time, not wanting to revisit the past, so on and so forth. So what did we find out? So on the one hand, over here, the touch point areas are the broad-ranging areas that people talked about. None of these will be surprising to anyone here. You will have seen them many times before. Carers came up as an issue, continuity of care, social connection, communication, service engagement, and public and private information were the broad-ranging touch points. Social connection was important because when we started the trial in true government fashion, they also decided to decommission all of the services that were delivering recovery support services and commission a whole new model. And so they moved from being group-based services where a lot of people would have come in and visited and had lots of social connection to an individual outreach model. So this was very tricky in terms of also coordinating the co-design meetings and bringing people together on the ground. I wanted to point that out because groups came up, there was a bit of noise in the trial, but people weren't just talking about the availability of groups in this scenario. They were also talking about having the potential to go to a group with other people like them, so to speak. So instead of having a group that was simply because people had had a lived experience, they really wanted to connect with people who might have been to different education settings like them or had children and had some things in common. So they really wanted to see a change in that. Communication similarly comes up again and again, and the carers was much around, again, communication and processing information. People wanted to see integrated services and co-located models, but it really was not within the scope of the trial to address some of those issues, but they did come out as important. So just going back to the co-design stage, we've gone through the experience and now we're going to the co-design. We invited people to have some training and orientation, and then we had two separate groups as our co-design. So one is a collaboration group and one is a co-design group. And what happens with the collaboration group is that they're responsible for this co-development of some objectives. They're made up of a group of people who will be service users and carers, but strategically identified staff who are in higher level management positions who will have authority to implement the changes. So that was a particular feature of the MHECO model. And then those improvement objectives, which are co-developed collectively, are handed over to a co-design group, and the co-design group undertake the iterative process, looking at mapping for the sticking points to try and find the ways to make change. They brainstorm evidence and have a look at what they're going to focus on, and then they developed action plans of the what and how. We've been reflecting on this a little bit about so much planning that you never do anything, but the groups did come up with a lot of detail in all of the plans, and those plans were then given back to this collaboration group, and as part of our adaptation of MHECO, we asked them to complete an implementation plan to really highlight how things would be implemented, by whom and by when. So we then went back to them and said, could you please report every quarter on how you're going? So we could also keep track of how long their implementation phases took for some of those changes as well. And this is all the focus of process evaluation work going forward. So just as an example, with the improvement areas prioritised, some of the things that people came up with were communication about what's going on, staff responses and service engagement. And I thought, we're still back at communication. Like, what's going on here? I thought, no one's going to be interested in this. But apparently, in medical anthropology, there's a whole field called the study of boring things. And so I feel like we've got plenty of content to go on with in that context. But I'm making a bit of a joke about that, but this stuff is actually very important. And particularly the second area where the voicemails were changed and the phone systems were changed service-wide, that was a big improvement when you reflect on it. This was about people getting phone calls and they didn't see who was calling them, they'd missed their appointments, they couldn't then contact the service because the service just had voicemail, the message was horrible and unfriendly, all of those things that are, you've heard them endlessly again and again. So even though sometimes we write things off as the small things or the quick fixes, they're also very important. A little bit of a flavour of the other things implemented. Some places did claim that they redesigned their reception, and I'm actually struck that in that reception room it was the same green as these chairs. But when I'm just thinking about it, but the challenge for the services was that you've got this trial that was implemented by the university, got some really interesting areas that could have pursued, matching people to groups, could have been an app technology, all sorts of things. And this redesign of the reception space could have been quite innovative, but of course the resourcing challenges were a big issue. So there was no real funding to give the services extra support to say, okay, get really innovative and go forward and create new solutions. Okay, so we were powered to detect a small difference, and Patty, our statistician, who, if you ask difficult questions, I'll send them to her to answer, conducted an intention to treat analysis. And so what did we see? We've found, here's our service user baseline characteristics. So people came in on the recovery assessment scale at about 86 to 87. Now, in my reading of the literature on recovery and use of this scale, this is actually quite common as a score. People tend to come in around this level, which is an interesting thing to reflect on. And the range goes up to 120. So I guess in the early days we were thinking that there's room for things to shift. And people were sort of in the mid-range of their quality of life. As I'd already said, they had 18 to 19 years of mental health conditions. People self-reported their hospitalisation more in their 30s than at younger ages, and that was self-report, so we don't know. And they've been involved in their caring relationships for 10 or 12 years. So once we went through and undertook all of the waves and kept everyone engaged over the time points, what did we see? Who wants to guess? Didn't bring jelly beans. So there was no evidence, null effect, to support a difference in recovery assessment scores between the intervention and control phases. You'll see slightly there that the intervention are lower than the control. There's no statistical significance or difference in that. There are some patterns that we're exploring around that. And that's the same for their quality of life. And this is the service user primary outcome. This carers reflect a similar trend also. So we were just talking about that a little bit earlier around the patterns and what to make of it. So it does raise this question of value, and it raises this question of how much change, as you remember right back to the 25 slides before that I've presented, how much can engagement make a difference on health outcomes, and should it? This is the question that we're asking. And in the end, I was reflecting also on this with someone else the other day. I said, it kind of makes me think we don't play that much of a big role in people's lives in all of this improvement work that we're doing. I thought that's helpful, something to think about. But I do want to return to the fact that it's possible that boring things are still important. And the things that were coming up around that communication were still around not being told what's going on, not feeling encouraged for outreach visits, to make contact with a service, and not being told what's wrong. And I think they're very important things if you think about going back to experience-based co-design and the ways in which people come in touch with a service. If that's how you're coming in touch with the service, that's what's going to shape your experience going forward. And so we do need to still focus on these areas and think about what are we not getting right in our service design at the early stages for this stuff to still be going on, particularly at such a scale across so many services at least in Victoria. And I guess we might immediately ask the question, oh, of course you're not going to see an impact on recovery with changes to communication systems. But it does suggest, as I was just saying, that those touch points are important to people. So maybe we should have seen a difference, maybe not. You might say we didn't measure for long enough. There's a whole range of things going on. And then we might say, well, there were a lot of other systems conditions at play. I mentioned there was a big service reform in the beginning. We also landed ourselves at the end in another national reform of the National Disability Insurance Scheme, and everyone became very caught up in that. They're very concerned about transitioning to another new service model, slipping through the gaps. The staff were very concerned about their ability to have a job, all of those things, which then made this work far less important to them as well. So I think looking back, we can see that a lot of solutions were implemented, but we need to possibly also explore how much people were still engaged in that process. How much did that relationship continue over time throughout the process? And we do have to ask this question of can we and should we expect system or individual value in these ways from such methods and methodologies. And I think, I've got to say it now because I know Glenn's waiting to ask. At the end is the effect, because we didn't have designers involved in the co-design. It was very structured and very, very routine. But when you look at Amanda, again, coming back to the person, when we interviewed her about her experience, she suggested having a voice, attending the meetings. For me, that was a really big step in my recovery. It was good for my recovery goals. I suffer from a fair bit of agoraphobia and no confidence. So just to have the confidence to be able to speak up, talk and use my intelligence, and I don't often get to do it, just having a voice, being able to say, hey, this doesn't work, and someone actually listened to us, still is there. And you'd say, well, that's recovery, so why didn't it show it in the outcome? And so the second question that it poses is maybe that being together brings things into being in a way that works for people, but once they leave, it's distal and it goes away and they lose that sense of hope and confidence and the goals and connection. So in a more theoretical piece of work that we've done, we've talked about this as this participatory paradox and this whole concept of a structure of feeling. And this is work that Glenn and I have undertaken with other colleagues, thinking about the whole movement of participation and co-production and co-design in and of itself as these areas of social experience which are currently being defined. They're almost still in process. They have emergent and connecting and dominant properties, but they still have a hierarchy. They're there and they're a mood of our times, but they're really hard to pinpoint and nail down. And I think we have to think about this because just the other day I saw something from the Carnegie Trust here around co-production of evidence. And one of the quotes within that is, co-production's a way to achieve positive outcomes for people and communities. So surely we should be measuring those outcomes rather than the co-productive processes that achieve these outcomes. So this is a very big and real problem that we have in the field that we need to untangle and think about going forward. So I reckon Da Vinci will answer it, the great Renaissance man, no problem. But I do want to return back to him and thinking about balance and the idea that, you know, once you have everything in proportion, things should all almost work out. And so we need to ask ourselves, where do we need to shift the weight of our attention? And Da Vinci was also into watching birds and how they flew and how they shifted their weight to glide through the sky as well. So in terms of this balance and where we might put our attention, our other work has started to look at, some of you might be familiar with it, others not, what is this anatomy of co-design and co-production in a sense? and thinking about these 8 mechanisms that one might see as being important to the processes. And of course, this is helpful because it helps us to then apply this to our data to say, okay, were these things at play or not in the settings? Is this part of the reason why we've seen the outcomes that we have seen? And those mechanisms are around recognition, having experience valued equally as other forms of knowledge. They're around dialogue and the dialogical ethic of seeing ourselves as interconnected. They're around a real attention to cooperation and working together, being accountable, having a sense of mobilisation for change, enacting things in a creative way and achieving attainment. And in some ways, maybe we need to shift the balance for co-design and co-production to this relational context. And part of what we put forward with the mechanisms of change that you just saw is that they exist in an interrelated context of relations. And these are not linear, they look very linear and neat. They should just sort of be scattered across the page in many ways. But, these are ideas that Wayne and Rosemary and myself sat down and brainstormed around. What do you think is going on when you're sitting down and doing co-design with people? And in a sense, this began with Wayne saying, oh,